Assalamualaikum and good morning, everyone. So, so happy to be here, and it's an honor to follow Prof. Kijin and Dr. Surya in this plenary. So I actually arranged this plenary. I'm regretting a bit putting myself after the both of them because I have a very high bar now to follow. So I'll be speaking about this topic, a block for everyone, changing the paradigm one block at a time. No disclosures to declare. And this is where I work. Nice to see a lot of familiar faces over here. Hospital Canselor Tunku Mukhriz, UKM. This is where I like to spend most of my time, in the regional corner, of course. And this is probably the third time I showed this slide at a conference, probably the last time I can do it. So I was in Toronto last year, where I did a regional anesthesia fellowship. So this was, during some months, this was the walk to work. It's very interesting, very cold, not always fun. And the other big thing is the food, not very good. So this is the national dish of Canada. I'm not sure if Kijin Chin will agree with me, but yeah, this is probably the most famous dish, and it's pronounced poutine, so that tells you a lot as well. But you know what? Being there was a great thing because I was able to work directly and learn from Prof. Chin, and of course, make a lot of friendships along the way, which I like to maintain as long as I can. Okay, coming back to my topic. So a blog for everyone, but I put an asterisk there. If anyone has watched the Thunderbolts movie recently, okay, the asterisk means there's a hidden meaning behind the statement. Now, obviously, there's no way we can block everyone. So probably the real title will be a blog for everyone who has provided informed consent, has no contraindication, is undergoing a procedure amenable to regional anesthesia and analgesia. But of course, that doesn't sound very catchy as a title, so I'm just going to remove that part and focus on a blog for everyone. So I'm going to talk, the focus is on surgeries where you can actually perform a nerve block, where you can perform under regional anesthesia, like joint replacements, knees, shoulders, and hips, laparotomies, breast surgeries, hip fracture surgeries, thoracotomies, and so on. So the idea of doing regional anesthesia for everyone is not a new one. It's been proposed as long ago by Gupta in 2012. So where are we? Have we actually achieved this, or are we anywhere near this goal of getting a block for everyone? But before we can appreciate that, we need to look back a bit. So we go back in time, maybe before some time ago, where the question was instead of a block for anyone, for everyone, maybe the question should be a block for anyone. Did anyone even get a block in the past? So maybe not this far back. Perhaps the best way to tell this story is I want to introduce a tale of two Tonies. So this is Tony. He is an AI generated person. You don't have to feel bad for him. But Tony has knee pain. He has a bad chronic knee problem, okay? Osteoarthritis and so on. So in this world, Tony had knee pain. He went to the hospital, had an x-ray showing severe osteoarthritis, had surgery done. So in this world, there were no nerve blocks, okay? No regional anesthesia, no nerve blocks. They did the surgery fully under GA. So as many of you can attest, this is what you'll expect in recovery. Tony's in a lot of pain. The nurses or the doctors attend to him, stick a bunch of opioids in him. Still a lot of pain because we start slow, right? Like 1 mg or so on. But at some point, after sticking a lot of opioids in him, he goes to sleep. And you can see the saturation has dropped as well. Oops, we missed that. So now he's in the ward and Tony's in pain again because the opioid has worn off. And they put more opioids in him, starts vomiting, more opioids in him, goes back to sleep. So he's not going to be doing any physiotherapy, he's not going to be doing any movement, he's not going to be doing anything to facilitate his recovery. So after a few days in the hospital, Tony eventually goes home. He's in pain again. Okay, he needs a walker. He's taking his oral pain medications. His wife is there. Wife is trying to encourage him. And after some time, the pain eventually resolves. I don't know why the AI decided to put two Y's at the end. I don't know what went wrong with the prompting, but I just put, can you make Tony happy? And there were two Y's. So I will stop there. So this is the old paradigm. a world without regional anesthesia, a world without nerve blocks. And this is what we know. We know that the new paradigm is you give a patient, you do the surgery under regional anesthesia, or maybe even TIVA, and patient comes out comfortable. With some time, they're doing this in the recovery, a little bit of time, Tony is flirting with the nurse and ready to be discharged from the recovery. So now he's in the ward, chatting with his wife, a little bit of time, he's eating. The food doesn't look good, but he's happy. So this must be in Toronto, definitely not in Malaysia. And a bit more time, and Tony's walking. But you know what? The reality is when he goes home, same thing. He's in pain, takes meds, still in pain, lots of physio. At some point, he feels better. Okay, so this is something we can't quite change much with regional anesthesia and peripheral nerve block. But if you look at it from the start to the end, have we really made a difference by introducing regional anesthesia in Tony? Because you look at that, it's a pretty big difference. Maybe not in the context of the long term, but it means that for that duration, Tony is in hospital, he feels much better, he's discharged earlier, his whole experience is much better. But the problem is, for every Tony who gets a block, we have 3 Tonys who don't. That is where we are right now. And this is something which is very surprising because as this article by Prof. Chin and team, they had this very nice graphic where they showed the expected trajectory of patient access to regional anesthesia. You can see in the image towards the right, patient access should have been prioritized from 2021. I mean, even before that, we have ultrasound visualization of LA spread, advent of ropivacaine, and so on. So we are now here. Why are we not on that upslope where almost everyone is getting regional anesthesia or peripheral nerve block? But you know, this is not just a local problem. This is a global problem. Let's take the US, for example. So they don't have an issue with resources. And this is what they find. Even with different types of surgeries, the utilization of RA and nerve block is very, very low. It's very centralized in the larger hospitals, the teaching hospitals, but overall, most patients don't get a nerve block or regional anesthesia. Same thing here. This is another study, and they looked at neuraxial anesthesia in total hip and knee arthroplasty. And though there has been an increase from 2006 to 2012, it hasn't been as much as we have expected. And as I said, the highest utilization is in the large teaching hospitals. This is looking at outpatient surgery, the kind of patients where you really want great pain control. You can see overall, only 3% of patients get peripheral nerve block when they are amenable to it. That means they're getting surgery where a nerve block can be done and they're not getting it. If you compare 2015 to 2010, the frequency has only increased from 3% to 8.9%. So again, not as much as we hope. So this is data from my hospital, from our regional anesthesia registry. So we can break it down. The blue line is the total knee replacements. The red line is which ones get blocks. And the yellow line is the percentage of knee replacements which get blocks. I think everyone knows what happened in 2021. Not a fun time. So we hit rock bottom there. But you can see subsequently the percentage of TKRs which get nerve blocks is gradually increasing, but it's still not everyone. Not everyone is getting nerve block. In fact, in 2024, we had a drop in the number of TKRs who got nerve blocks. So we don't actually know why, but it's in our data. And just for interest, you can see the percentage PNB by type in a hospital. Most of the time we do an ACB. So we actually at some point did more. We did more IPACs, but now we've decided to focus mostly on ACB. So again, coming back to this point, why haven't we reached that sudden increase or sudden availability of regional anesthesia for everyone? So that is a question I'm posing right now. It's a big dilemma, and it's something we need to address. So let's look at countries with resource limitations. Maybe they can explain why we're not doing more. So these two studies look at reasons or barriers which are limiting the use of regional anesthesia. So the reasons are as much as you expect: lack of equipment, lack of medication, lack of training, lack of time, and other stuff. Other stuff means someone else has discouraged you from using. we look closer to home, this study in India, the reasons are pretty much the same. At the bottom, most of them say time is a factor, surgeon factor, equipment issues, knowledge or training, patient refusal, and cost. But if you think about it, most of these things can be addressed. They are clear things which just require money, time, and training. Is something which there are plenty of articles like this by Ramlagan and team addressing how best to train people in regional anesthesia. We know that simulation-based training is the way to go, and competency-based training in regional anesthesia. And there are a lot of programs out there you can take to train. Of course, you have the Malaysian subspecialty program, which is great, but you can't train everyone. So for the rest of us, we can take these diplomas from all over the world. But I would suggest that the bigger problem is humans are inherently stubborn. So we had a pre-congress workshop recently where there was a very good question from one of the participants who said that he had a surgeon who refused to allow regional anesthesia. And I'm sure many of you have seen this. Like no matter what they refuse, no matter how much you talk to them, they're not keen to allow it. So inherently, people are resistant to change. So in this article we published in MyJow, it's focusing on something else, ultrasound-guided CNB. But we talk about something interesting, the Lewin's change management model. So how do you get people to change? So the way is not to directly speak to them, so not directly trying to convince the surgeons or stakeholders or other anesthesiologists how to change. The way to do it is, first you need to unfreeze. This basically means you need to recognize the need for change, determine what needs to change, encourage replacement of all behaviors and attitudes, ensure there is strong support from management, and then manage and understand the doubts and concerns. So the first step is to unfreeze. The next step is to initiate the change. So this is where you plan and implement the change. You help everyone around you, like the nurses, the APS team, and so on, to learn the new concept, points of view. And finally, you have the refreeze, where you keep that change, the change that you just made, we reinforce it and stabilize it so it stays. Integrate changes into the normal way of doing things, develop ways to sustain the change, and once the change has been made, once that surgeon decides like, whoa, okay, I see that most of the patients are comfortable after the ductal canal block, the canal catheter, right, so I'm happy for you to do it, so it's time to celebrate. So is that enough to do a block for everyone? Okay, I'll offer one more perspective is we need to understand that a block for everyone isn't just for one person, not just for the patient. Yes, the patient is the most important person when it comes to the block. We talk about regional anesthesia outcomes. What does regional anesthesia actually do for the patient? This article looked at it from 3 points of view. From the patient's point of view, the surgery point of view, and the institutional point of view. So from the patient's point of view, what does a block really mean for the patient? So we already know that, as in Tony's example, this is what getting a block, getting a regional anesthesia mean. A much more comfortable experience during surgery. We know that regional anesthesia is the best way to manage pain. The prospect guidelines, 19 out of 26 of their published guidelines recommend the routine use of peripheral nerve blocks to manage pain. And we know that there is something called rebound pain, but we know that with regional anesthesia and multimodal analgesia, you can avoid it, and you can avoid the trajectory compared to someone like Tony in the first instance who did not get any regional anesthesia, any nerve block. We also know that regional anesthesia reduces the risk of PONV. In fact, it's strongly recommended to use regional anesthesia to reduce the risk of PONV, and it additionally reduces the amount of opioids the person needs to take. And this ICAROS systematic review and meta-analysis, what they found was neuraxial anesthesia was associated with lower odds or no difference in nearly all reported complications. They looked at major complications associated with knee arthroplasty. And they recommend that neuraxial anesthesia should be preferred for knee arthroplasty and hip arthroplasty. So you're not just looking at the small things like PONV and pain, but also the major complications. But there's some areas which are not so clear, more gray, like does PNB actually reduce risk of post-op delirium and POCD? So in summary, we don't have enough evidence to say yes. Most of the studies so far have showed no difference. What about cancer recurrence? There was a lot of excitement many years ago that regional anesthesia might reduce the risk of cancer recurrence, but the Cessler study has poured a lot of water on that. And again, the evidence is not very clear. What about mortality? Same thing. The earlier, older studies, cohort studies and all, showed that mortality may be reduced, but the newer, well-designed trials don't show the same finding. But then you ask yourself again, today, surgery has become so safe, GA has become so safe, that outcomes like mortality shouldn't really be used as outcomes when you're talking about RA versus GA. It should be the outcomes such as the ones experienced by Tony, pain, PONV, and the earlier ability to ambulate. And the most important question is, what would you choose? If you yourself had to go for surgery, if you yourself, a family member, a loved one had to go for surgery, would you want a nerve block to control pain? I had 3 knee surgeries, 1 without a block, 2 with blocks. I can tell you, I want a block every time. Okay, definitely I want a block. And so does Tony in the future. The other aspect you need to look at is the block for the surgeon. So all the reasons I mentioned earlier is beneficial for the surgeon. The patients eat faster, move faster, they don't get ileus, they walk around, they don't get stiffness, get to do physiotherapy faster. So these are all some things the surgeons like. It's just that you need to show them that it works. And something which really, really works is in vascular surgery, we know that regional anesthesia is strongly recommended. It can keep the AV fistula patency rate higher. So that's something very specific. Another aspect is looking at what does a block do for the institution. So again, look at Tony who got a block situation. He's sleeping happily, playing with his phone, chatting, up, eating, out. Definitely will help the healthcare system. Okay? He doesn't have to stay as long in the hospital, and this is proven by evidence. So this is a study looking at hip and knee arthroplasty, and they found that using PNB, peripheral nerve blocks, is associated with reduced length of stay, a median of 1 day, which is a big difference, especially from the healthcare system's perspective, lower rates of ICU admission. This is another study closer to home, a retrospective cohort study in Singapore. So they looked at GA versus RA for length of hospital stay in TKA. And they found that on average, you stay 0.93 days longer when you use GA compared to RA. And the length of stay was more than 6 days, for 45% higher for GA versus RA. And we have some people from ED here, Dr. Gunn. So this is another example when they started introducing interscalene blocks for shoulder reduction in the ED compared to the traditional method of using procedural sedation. And what they found was when you use a nerve block instead, you save 77 minutes. Maybe from an anesthesia point of view, it doesn't seem very long, but from an ED, busy ED point of view, 77 minutes is a big deal. Right, Dr. Gunn? I don't know where you are. So at the same time, mean one-on-one healthcare provider time is much shorter when you use the block compared to the sedation. And there's no difference in other outcomes such as patient satisfaction, pain scores, or hypoxia or hypotension. And one often forgotten perspective is, what does the block do for the nurse? Again, look at Tony's example. Which Tony would the recovery nurse rather have? The first Tony or the Tony who got the block? I don't need to say anything else. But except the second Tony is flirting with the nurse, so that's not good. So a block for the earth is the last aspect I want to talk about. So we tend to forget this often, that there's a lot of discourse about how we are contributing adversely to pollution, the environment, with the use of inhalation anesthetics, disposables, and so on. We do know that regional anesthesia actually has a lower carbon footprint, even when you consider things like using gowns, the packaging for all the RA equipment, and so on. And in this daring discourse, they showed that you actually, by avoiding GA in this 1 year, in 2019, they prevented the release of 0.4 to 2.2 tons of carbon dioxide equivalents into the atmosphere. So the footprint of regional anesthesia is just way lower than general anesthesia. And this has been, again, in the study from the WFSA, they basically said that the best way, or one of the best ways to reduce the carbon footprint is to promote regional anesthesia and increase the training of regional anesthesia. The last thing is, what does a block do for you, all of you over here? So I can tell you what a block can do for me. I mean, look, if a patient is like this, surely you feel better than the other Tony, right? This is what a block can do for me. These are all our patients. The first is post-op day one, post-op few hours after TKA. The second one, post-op day one TKA. The third video I got from Dr. Tan Kok Wang is one of our patients who had an EOI catheter after laparotomy. So they're all very happy. And that nothing gives you a better job satisfaction than seeing this. This is a small article I did with Dr. Louis. We published in Verita. So this is a patient I had in Toronto, and she had a total knee replacement. And she had a nerve block catheter. She had spinal anesthetic, and the special thing was I followed up on her specifically because I wanted to write this article. And I can't tell you how good it felt just seeing how she was recovering, even though she had pain at home. It was a struggle for the first few months, but ultimately the whole experience was great because in the hospital she had really, really good pain control. And these are just all our patients with rib fractures, trauma patients who get PSP catheters. This is a gentleman who had to be brought into the ICU for NIV because of multiple rib fractures. So we did a serratus plain block. So this is the video before the block. So we were asking him his pain score. He's a very funny uncle. So he said 5. It wasn't too bad. But he said 5 when he doesn't breathe deeply. But if he does take a deep breath, he says that the pain score is 5 times 2. So he was very clear. So it's 5 without deep breathing, 10 with deep breathing. So he could say that very clearly. And of course, when you look at the monitor, you can see blood pressure is high and so on. It's because of the pain. So we did a serratus plain block, and we asked him again. And within a few minutes, what was your pain score now? We didn't want to move him, hence we did the serratus plain block. He said 0.5. So that's 0.5, really 0.5? He said, yes, correct, 0.5. He tried to write it on an imaginary whiteboard, and he moved his hand up and down. He's very, very happy. And can anyone actually tell me that is not fulfilling? That is not job satisfaction. And of course, the other part of regional anesthesia is you get to meet all these experts, you get to network, you get to learn from them. So ultimately, a block for everyone doesn't just mean every single patient gets a block. It also means everyone benefits from the block. The patient, the surgeon, the nurses, the healthcare institution, and you. So this is a nice quote by Ed Mariano, who said that for RA to improve outcomes, it has to be accessible to all. So how do we achieve a block for everyone? We need to change our practice. Okay? We need to learn to unfreeze the bad habits, promote change, and refreeze the good ones, which can make a difference. The most dangerous phrase in English language is, we have always done it this way. We must be always open to change and learning. So ultimately, what we want to do is, we want to change the paradigm. And that's it. So thank you, everyone.